This is a very anxious world in which we are currently living. Arguably all times are anxious times. Certainly living during the Blitzkrieg in England, or try living a normal life in the midst of a modern-day war, let alone fighting in that war. This worldwide pandemic has forced us to mask ourselves and mask our children due to contaminant concerns. Our faces uniquely define us as distinct individuals, and so much of human interaction is built upon facial cues, recognition, and individuality. Not having this ability and individuality is definitely anxiety-provoking. In this novel pandemic era, which hopefully is drawing to a close, we have all experienced that evolving, confusing, conflictual, changing, crucial survival information that we get. All times are anxious times in their own rights for differing reasons. All the more reasons for this program. Hi, I'm Dr. Renee Kohanski, and welcome to episode 16 of Clinical Correlation. This is a two-part series, and to be clear, I'm going to be talking very globally about anxiety disorders such as generalized anxiety disorder, panic disorder, bit on social anxiety, or social phobia. I'll be abbreviating that as SAD, but don't confuse that with seasonal affective disorder. In discussing specific agents, I'm not going to be talking about them with respect to depression or PTSD. So when I talk about their indications, like for example in sertraline, I'm not going to say they have an FDA approval for depression. I'm not mentioning that at all. So don't get confused when you hear that. When I talk about the indications, I'm only talking about FDA indications with respect to the anxiety disorders. And while I'm sure everyone is familiar with pharmacologic treatment of anxiety, given my intro, I believe a good overview with some juicy clinical correlation is timely, so I hope you're all hungry. In the pharmacology realm, of course, we all often go to our favorite class of drugs, which are the SRIs or the SNRIs. They're safe and, generally speaking, really easy to prescribe. But a word about my favorite class of drugs, and probably yours too. In case many of you didn't know, we are technically using many of them off-label. Dr. Robert Emmons and I recently wrote a piece on this, which is published both here on MDedge and in Medscape. And it's worth the read, especially for the comments. What I found interesting is that, I understand that the lay public doesn't understand about off-label prescribing, but I figured that almost all physicians knew about it, understood it, and in reading the comments, I realized that they did not. I mention this because it goes back to one of my earlier programs where I said, as physicians and actually as healthcare providers across all areas, we have an obligation to educate the up-and-coming generation. And when I read that, I thought, you know what? Maybe we're not getting our message out there enough. And so we really need to do that. In psychiatry, we're very comfortable in the land of off-label prescribing. We do it all the time. And of course, just to review what that is, off-label simply means we prescribe a medication that we think will work for a particular disorder, even if it doesn't have FDA approval for that disorder. It has happened sometimes that after we've used a medication for a while, a drug company might even go back and seek FDA approval for that medication. From the physician's perspective, it's necessarily always how to best take care of our patients and obtaining an informed consent to do this. And I'm saying this not to criticize drug companies. Well, not for the purposes of FDA approval anyway, getting an indication. Sadly, for a drug company to get a candidate to market is exorbitantly expensive. So, of course, it has to be worth their while to want to do that and get the FDA approval on a drug that's already been successfully marketed and even successfully utilized off-label. And then from our perspective, if they want to then go, say, get an FDA approval on a drug that we are already using off-label and perhaps has gone generic, if they go back and get the approval, they may now take a drug that's generically available and create a new drug that is now only available in a name brand only, and we then have to get a PA and it becomes an expensive drug, and it's not necessarily a win. So these are clinical correlations that are all becoming very interesting in the practice of, I would call that healthcare. So let's talk about the following SSRIs and SNRIs. Number one is escitalopram or Lexapro. Now, interestingly, this is FDA approved for GAD, but used off-label for panic. Little pearl here. It is one of the best tolerated antidepressant, anti-anxiety medications, whether we are using it for anxiety or depression. Another pearl. When dealing with anxiety disorder in general, in case you don't know this already, we are always going to be looking at the, well, not always, never say always, at the higher dose range. But because these are anxious patients, and especially if they are naive, we are going to always go low and slow, always, and never say never, never say always. So this is kind of where the art of medicine comes in. Our steady, confident hand will be going a long way towards helping our patients on board. Now, with escitalopram, I actually don't find much difficulty in onboarding. And as you all know, this is a very easy drug. It has a very small dose window. It's basically a 5 to 20 milligram dose window, and you can go as low as 2.5. Okay, next, escitalopram or Celexa. It's, again, we're not talking about depression. Obviously it has the on-label depression, but ironically, though escitalopram is the S enantiomer of citalopram, it is less well-documented efficacy in anxiety, and I don't even know if it has an off-label for anxiety. I actually don't use it for anxiety, but I imagine there are people who do. Sertraline, Zoloft, interesting, only on-label indication, again, we're not talking about depression, is social anxiety disorder. Of course, it has the depression on labels, but we're talking anxiety. The only on-label indication is social anxiety disorder. That being said, I use it all the time off-label for GAD and sometimes for panic. Again, we're talking higher dosage, so I'm typically pushing, at 150, maybe even 200. The problem is, for me, in my experience with sertraline, and certainly other people as well, especially at the higher doses, and more particularly with women over 50, I'm seeing more of that emotional flattening of responses at the doses of 150 and above, and those are the doses that you need to kind of hit the anxiety disorder. Not always, but sometimes. On the other hand, again, informed consent, risk-benefit, I'm finding that the relief from the anxiety disorder often outweighs the flattening of affect, but you don't always get it. So again, pearls, this is just where I am. I find it's a really helpful drug for anxiety disorder. It has the FDA for social anxiety disorder, doesn't have the FDA for GAD. I find it helpful for GAD. Paroxetine, another interesting story, has FDA for GAD, social anxiety, and panic. And while it has the FDA for many indications, I had stopped using it a number of years ago because I had such difficulty getting it off. Plus, I saw so much weight gain. And while most SSRIs are listed as weight neutral, paroxetine does have weight gain as a side effect. However, interesting about paroxetine is that GYNs like to use it for perimenopausal flushes, what we call hot flashes, and it actually has an indication for vasomotor symptoms, and it has its own very special brand name called Brisdel. Brisdel is simply paroxetine at 7.5 milligrams. Incidentally, my family practice doc friends tell me that they also use low-dose venlafaxine ER for hot flashes or flushing. I find this is why I love our job. It's such a great job. I find this all especially fascinating because all SSRIs, SNRIs, and bupropion have sweating as a side effect. And here we are using it for hot flashes. Okay, next SSRI, Vlazadone, strictly off-label on anxiety. Not my first line for anxiety ever. It's a really activating drug, but it has its place in medicine, just I don't think here, but never say never. Things to remember about Vlazadone: you have to take it with food. It can cause intolerable diarrhea, but there are mitigation strategies for that. This drug's superpower is its dual serotonin action, acting as both a presynaptic push and a serotonin reuptake inhibitor. Also, for some, it's marketed for its less sexual side effect. I have seen it sometimes, not always. More on this in a depression program. Again, it's off-label anxiety. I'm trying to think if I've ever used it for anxiety. I'm sure I have. The fact that it's not coming to mind makes me think that, it's just not where I go. Okay, SNRIs. Interesting little group of compounds. Interesting. Numero uno, duloxetine. Cymbalta. It has an indication for GAD. And I'll also mention, as we all know, it also has a diabetic peripheral neuropathy. If you didn't know, it's worth knowing, also chronic musculoskeletal pain. And I'll tell you why. By the way, most SNRIs cover neuropathic pain to some degree, though duloxetine has the approval. And since it has the approval, I have found that a lot of my chronic pain patients have associated anxiety. And because of this, duloxetine becomes the first-line agent for anxiety disorder. Now, that being said, by the time these patients hit us, they're probably already on duloxetine. But if they're not, and someone's coming to us with the primary GAD and any kind of pain syndrome, and if it's not a peripheral neuropathy, it's probably a musculoskeletal one, duloxetine's your baby. And if they come to us and they're on 60 milligrams, it's worth the push going above the quote-unquote recommended max dose, because I will go certainly to 90 milligrams. I max out at 120. And but I'm not going to spend a lot of time there. So if they've had a response at 60 and maybe they flattened out their response, I will push to 90, hold for 2 weeks, and then go to the 120, hold for 2 weeks. And sometimes I'll recapture some people I've lost. So that's my story on duloxetine. Venlafaxine, Effexor. On label for GAD, on label for social anxiety, on label for panic. An oldie and a goodie. It has the FDA stamp of approval for everything. I like this drug. It's cheap. Just remember, at lower doses, you got an SSRI. You do not have an SNRI. You really have to get probably above 150. 112.5 maybe for maybe some slow metabolizers. But really, I'm thinking 150. Do check blood pressure and pulse baseline and periodically, as it can bump generally not more than 5 millimeters of mercury. So now on to desvenlafaxine, or Pristiq. Note the very interesting spelling of Pristiq. So if you want to avoid those dose-related problems of hitting an SNRI, you can get the pure SNRI at starting dose. And while it has off-labels only for GAD, SAD, panic, I personally don't use this agent for anxiety disorder because I have really just found it too activating, even at a starting dose of 25 milligram. Now, there are clinicians that have had success with it. I'm just not one. Who knows? I may yet run up against a case where I use it. You never know what unusual set of circumstances take you down a particular pathway. Just remember to watch blood pressure, pulse, and remember, with all of our agents, when you need to include a risk of activation for suicidal ideation. So this brings us to the conclusion of the first part of the anxiety disorder program. Ending with venlafaxine and desvenlafaxine is perfect. This is exactly why this is an art, because here we have two drugs. One is the active metabolite of the other. Both essentially same mechanism of action, with the exception that venlafaxine doesn't become an SNRI till higher doses, and desvenlafaxine immediately starts as an SNRI. I personally have not found off-label useful indication for GAD on desvenlafaxine, while I have had success with venlafaxine. Venlafaxine has an on-label GAD. On the other hand, sertraline does not have an on-label GAD, yet I've had great success with this as well. Obviously, we all want to do the tried and true first. We want to exhaust methods we know with tested RCTs. But when we are faced with a patient who has failed everything, we then systematically work down our own decision trees using all our best tools. This includes an understanding of mechanism of action, pharmacokinetics, sometimes individual genomics, sometimes psychodynamic factors, family history, response, and clinical experience. Now, stay tuned for part 2, where we're going to discuss additional agents, augmenting strategies, non-pharmacologic interventions. I'm Dr. Renee Kohanski for Clinical Correlation.